Hello students, welcome to my challenging concepts video on the central nervous system part 2, so chapter 12 of the Marieb textbook. So we're going to start with the meninges first. Please remember meninges covers the brain and spinal cord and protects them, right? They protect the blood vessels, they form partitions in the brain, and they also contain the CSF within the subarachnoid space. So in terms of the layers, it's three layers. It's DAP from outermost to the innermost, dura mater, arachnoid mater, and then pia mater. And then the subarachnoid space is between the arachnoid mater and the pia mater. So where is the CSF produced? CSF is produced in structures called the choroid plexus. Choroid plexus are found in the four ventricles. CSF itself is a colorless fluid. The function is to support the brain cells exchange of oxygen, nutrients, waste products, as well as hormones. It also protects the brain and spinal cord as well. So it is produced in the choroid plexus. Choroid plexus are found in the four ventricles. They are made up of ependymal cells and capillary walls, right? So it's basically a filtrate of blood plasma. So let's talk about the circulation of CSF. We're going to start our journey in the lateral ventricles. Within the cerebrum, the choroid plexus will produce CSF. It'll go from the lateral ventricle into the third ventricle through interventricular foramen. Third ventricle is found within the diencephalon. From the third ventricle, they'll go to the fourth ventricle via the cerebral aqueduct. Then from the fourth ventricle, they have a couple of options. One is to go straight down the central canal into the spinal cord or go into the subarachnoid space. To enter the subarachnoid space, so central canals is just inferior to the fourth ventricle. To enter the subarachnoid space, they can use three openings, two lateral apertures and a median aperture, and they will enter the subarachnoid space. Even CSF in the central canal is going to go down the spinal cord and will enter the subarachnoid space. Once they're within the subarachnoid space, they again cover the brain and spinal cord, and then they will exit through structures called arachnoid villi. Villi are finger-like projections. These are found to increase surface area. So this will leave the subarachnoid space, light blue here, go through arachnoid villi plural, and will enter the superior sagittal sinus. So it is a venous sinus, so venous blood collects here, and then which enters the blood supply and will drain into the jugular veins. So it's continuously produced, it flows through, and then exits back into blood. Okay. Next, we're going to talk about the blood-brain barrier. As the name suggests, it's a barrier between uh, the blood, the contents of blood, and the brain. It is selective barrier, so it stops certain compounds to pass while it allows others. Waste products like urea, ammonia are not allowed to go in. Most drugs are not allowed. Potassium's not allowed, but some drugs do, like anesthetics, alcohol, nicotine will pass through the blood-brain barrier. Okay, some places we do not have a blood-brain barrier, or they're not complete because they want those structures want to be in contact with blood, and these are the medulla oblongata and hypothalamus as examples of them. So next we're going to go into our topic of spinal cord. So spinal cord starts below the medulla oblongata. In terms of landmarks, it starts at foramen magnum and goes all the way down to L1, L2 vertebrae in adults. In children, it's a little bit lower, so basically our vertebrae grew faster or at a greater speed than our bones than our spinal cords did. Um, at the end of the spinal cord, it does not end bluntly. It actually it ends in a cone shape, three-dimensionally, and it's called conus medullaris. So at certain areas, the spinal cord is a little bit thicker, wider. Um, this is going to be in the cervical area and the lumbar area. This is to provide the extra um, get information as well as provide motor to our limbs. Okay, then because the spinal cord ends at L1, L2, we don't want it to move around and hurt itself. So, like if you had a tent or a marquee, uh, we'll want to anchor it to the ground. So, similarly, the spinal cord is anchored to the coccyx using a structure called filum terminale. Filum terminale is basically made of the pia mater. Pia mater is just around our spinal cord. We have 31 pairs of spinal nerves, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. So 31 pairs. So there are spinal nerves coming below L1, L2, and they have to exit at that level. Okay, so they have to go beyond the inferior end of the spinal cord. So they are a collection of these fibers. If you've heard of equine, equinary, it's in reference to horse. Cord means tail. Basically, this translates to ponytail because it kind of looks like that, right? These fibers that are inferior to the end of the spinal cord. So it's the collection of them. Okay. So here's a view, a anterior view of the spinal cord, yellow with the spinal cord and the nerves. You hopefully can make out that it's a little bit thicker here compared to here. Similarly here, end of the spinal cord ends in a cone. In 2D, it's going to be a triangle. This green would be filum terminale, which is made up of pia mater, which anchors the spinal cord to the coccyx. And then the collection of fibers that come below the inferior end would be called cauda equina, right? Cauda equina. So I also wanted us to think about lumbar punctures, spinal taps they're called. What we are trying to do is to get some CSF, right? And the best place to go is, of course, below the spinal cord, but in adults, we generally go between L4, L5. So in this area, we will not have spinal cord because it would have ended higher up. We will go through, of course, the skin, all the subcutaneous tissue, some fascia, including ligaments. We will go through the dura and arachnoid and get into the space here. It's still a subarachnoid space, and then we will withdraw some CSF. Previously, we used to take CSF to diagnose multiple sclerosis. Now we do not use it for that. Our radiological technology has improved drastically that we are able to detect those changes on MRIs now. So this is usually used for meningitis, maybe even for hydrocephalus if you want to measure the pressure. Those are the two main common times we may use it. So let's look more in detail of our spinal cord. If we look at the spinal cord, we're going to see that there are two grooves in the middle of the spinal cord in a cross section, in a transverse section of the spinal cord. On the ventral side, it's going to be deeper, so it's going to be called the ventral median fissure, while on the dorsal side is shallower, so it's going to be called dorsal median sulcus. Then we also, of course, have gray matter. Gray matter is like a butterfly shape in the middle, opposite to our cerebrum, because there gray matter was more peripherally located, cortical region, while here it's centrally located. And here we also need to know that they are in the form of horns. You can see this kind of stick outwards, right? So dorsal horns, ventral horns, lateral horn, nice and easy. It's by orientation. So dorsal horns will contain the cell bodies of the interneurons. So dorsal horn will receive the sensory information from the dorsal root. So they have to convey this information. So they go from dorsal horn towards the ventral horn. So from the ventral horn, we have cell bodies for the for our somatic motor neurons, and they will leave the spinal cord in the ventral root. Lateral horns are only found in certain areas. These contain the motor neuron of the autonomic nervous system, the cell bodies of them. Um, so only found in a thoracic region and then a sacral region. Okay, dorsal root, I mentioned just a little while ago that it will bring sensory information on the dorsal side, of course, of the spinal cord and enter and meet the dorsal horn. Ventral root leaves from the ventral horn, and on the ventral side of the horn, ventral side, as well as it arises from the ventral horn, it will contain motor fibers. Okay. Then dorsal root, there's also, you can distinguish the sides by the ganglia. Ganglia are a collection of cell bodies found outside of the central nervous system. So here they are unipolar because they're general sense neurons are found in general sense neurons. So these are the collections of those cell bodies. Okay, so it will bulge out on that side, the dorsal root side. There will be a little bulge which contains the dorsal root, which is the dorsal root ganglion, which contains the cell bodies. Next, we're going to talk about the white matter. White matter is basically myelinated fibers. There's some unmyelinated, of course. They run, you can think of it as running in three directions, right? So running ascending fibers, which are going to take our sensory information towards the higher brain, so brainstem and beyond, while descending are bringing information down, and transverse, you're just communicating from one side to the other. The white matter can be divided into three columns of funiculi, funicular singular, and again it is by orientation, dorsal, lateral, and ventral. Dorsal funiculus is found between the dorsal horn and the median sulcus, while the ventral funiculus is found between the ventral horn and the ventral fissure, and then lateral horn is found going from, on the lateral side, from the dorsal horn out to the ventral horn. So we also have what are called spinal tracts. You can think of tracts as certain specific groups of neurons which are specific to carrying certain information. So they're going in a certain direction as well as certain information. And we will learn, we'll talk about three tracts, okay? The spinothalamic tract, the spinocerebellar tract, and then the cortico spinal tract. So here's a picture showing those. You can see the white matter, gray matter. So this is the dorsal side. This will be the ventral side. So you can see the dorsal root ganglion. Okay. So next we're going to talk about those tracks. Ascending pathway has 3 neurons in that pathway. Again, there are of course exceptions. This is the commonest one, so we're just going to talk about some of the common ones. While the descending pathway contains 2 neurons. Ascending pathway, it's called first order, second order, and third order. First order is basically the sensory neuron that comes from the receptors into our central nervous system, whether it's through the spinal cord or the brainstem. Then the second order starts from there. It goes up to the thalamus, and then at the thalamus, the third order begins, which goes to the cerebral cortex, right? So a couple of things to note. If it does not go to the thalamus, it may go to the cerebellum, like our proprioinformation. That will be the exception, will be one of the exceptions. You only have 2 neurons there. And please note, about 90% of these fibers, this information will decussate, and most of them decussate at the medulla oblongata. So first tract we're going to talk about is spinothalamic. These take information of temperature and pain. They will take into the spinal cord where it will synapse, and the second order neuron will go up the spinal cord all the way to up the spinal cord past medulla oblongata, past the pons, past the midbrain, and then to the thalamus, right? So this picture, which looks like a clown's face, is basically the pons in front, the mouth region, and then the eyes and the hair will be the cerebellum. Okay, so in the next tract, we're going to see that it comes up to the pons, it takes a turn to the posterior region and goes to the cerebellum. So this would be the thalamus. So the second order comes up to the thalamus, it will synapse there, and then third order will go to the primary somatosensory cortex found in the postcentral gyrus of the parietal lobe. So next we're going to talk about the spinocerebellar. So again, that kind of gives us direction, right? Coming from the spine, going towards the cerebellum. The last one was spinothalamic, coming from the spine, going through to the thalamus. So it gives you the direction it's going. So those are all sensory information. So spinocerebellar tract will take, spinocerebellar tract will take proprioception, position sense information. Okay, and this one does not cross over. So it will enter, first order will enter through the dorsal root, enter the spinal cord, it will synapse there. Second order will go up all the way up the spinal cord past the medulla oblongata. So this is the medulla oblongata. We'll go down, go up to the, so you can ignore the dark blue. Dark blue is the spinothalamic, while the light blue is the spinocerebellar. So it comes through the pons and then turns into the cerebellum. So please note here is that one exception I mentioned, we only have two neurons in this tract, right? There is of course communication between the cerebellum and our brain, our cerebrum, but that's not part of that tract itself. Okay, so you can take it as two. Then the next one we're going to talk about is the descending pathway. It contains two neurons I mentioned earlier, upper motor and lower motor neuron. Upper motor neuron comes from our primary motor cortex, which can be found within the precentral gyrus. So these are the pyramidal cells, very large cell-bodied neurons, and they will send the impulse. So I'll talk a little bit more about them when we talk about the corticospinal tract. And then the next order is the lower order, which starts from the spinal cord and goes to our skeletal muscles. So here's upper order beginning at the primary motor cortex. Please note, so primary motor cortex is found in our precentral gyrus. So it will come down. So they do use two parts, the lateral and then the ventral. Let's go down. There's two tracks for it, rather, should I say. That lateral one is the one that's used most often, and that will decussate, cross over at the medulla oblongata. So the magenta color is the lateral, the red one's the ventral. That'll keep going down. So the lateral will cross over at the medulla oblongata, go down, and then meet the final motor neuron at the level on the spinal cord. Whereas the ventral will go straight down and cross over at the level at the spinal cord, and then the second motor neuron, or called this lower motor neuron, which starts at the ventral horn of the spinal cord, right? So let's talk about some trauma or loss to function because of spinal cord, right? So paralysis and of course this can also be higher order, but these are more commonly seen in spinal cord. So paralysis is the loss of motor function. Paresthesia is the loss of sensory function. Then I also wanted us to differentiate between flaccid paralysis and spastic paralysis. Flaccid is total loss of innervation of those muscles, right? So there is no communication from the central nervous system to the muscle, and this is due to damage of the second order neuron, which is called the lower motor neuron, right? It's a better word. I shouldn't even use order. We use that for the sensory neurons, the ascending pathway. So it's the lower motor neuron. So damage to the ventral root, ventral horn can lead to flaccid paralysis. So even the reflexes are not intact. While spastic paralysis, the reflexes are intact because we still have the lower motor neuron, so sensory information. So you touch a hot object, the sensory neuron will bring that information to our spinal cord. It will go through the spinal cord and the motor neuron will move that limb away from it, right? So that the reflex is still present. Here, the damage is to the upper motor neuron, most likely, again, not exclusively, but most likely due to a stroke in the area of our primary motor cortex. It's the most common cause for spastic paralysis. The next, we're going to talk about transection. Transection is basically a cut through the spinal cord, right? So complete cut of the spinal cord, so there's no communication from that spot below, right? Whether it's motor or sensory. So depending on the level of the transection, we can have either paraplegia or quadriplegia. So quadriplegia is four quad, so all four limbs are affected. This happens when transection occurs in the cervical region of the spinal cord, whereas paraplegia occurs when we have transection between L1, T1 and L1, and we have loss of function and loss of sensation in the lower limbs. When we have trauma, a lot of time what we're hoping for is spinal shock. Spinal shock is similar to when you get hit in the head, right? When we get a bump in the head, sometimes we just get dazed. So it just goes dazed and it takes a little bit of time and it comes back. Spine obviously takes a little bit longer than that, spinal shock rather, because of inflammation, right? There's swelling, so there's function loss below that level. So what we are hoping for is whenever we see symptoms of either quadriplegia, paraplegia, that's spinal shock because it's transient, right? It comes back once that swelling goes down. So that's a quick overview of some challenging concepts on chapter 12, central nervous system. I hope you found this video useful. I'll catch you in another video. Have a great day.